America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right. Now, the lawyers tell us that we need to have a roll call, which is fine with me. I don't care one way or the other. So, Jessica, if you'd be so kind as to give us a roll call.
Chairman Fletcher,
Present.
Vice Chairman Jameson, Kootenai County Representative Dr. Johnson, Bonner County Representative Glenn Bailey, let's see, Benawa County Representative Peggy Krolla,
Present.
and Boundary County Representative Tim Bartling.
Tim? Raise your hand.
You blanked out. You blanked out for a second.
And Shoshone County Representative Commissioner Cowles.
Here.
Thank you.
Wonderful. Thank you. Public comment session. Anyone from the public wish to speak? Going once? Going twice? All right. We are moving on. Consent agenda. In usual fashion, are there any motions to extract an item from the consent agenda? I would entertain those extractions now. Going twice, any extractions? Okay, so the consent agenda stands as a motion. Do I hear a second for the consent agenda?
Mr. Chairman, I would move that we approve the consent agenda as given tonight.
Okay, a second?
I'll second that.
All right. In my usual fashion, are there any nays to the consent agenda? Going once, going twice. The consent agenda is approved. Item number 6, ballot tally for the Shoshone Board of Health position. I guess I turn it over to Eric or you guys. You have the information, the raw data. Okay.
Thank you, Mr. Chairman. Yes, we did. How many ballots did we ultimately receive, Jessica? So we received
That's pretty good.
14 of the 15
That's,
ballots.
in fact, that's better than usual.
13. So I do expect we'll have a decision here.
Okay, good.
Would you like to, Mr. Chairman, would you like to wait for them, or do you want to proceed?
Oh, that's a thought.
Either way.
Well, the next item is the strategic planning meeting is going to likely result in some discussion. We could begin that discussion, I suppose.
Well, Mr. Chairman, I think the items 8 and 9 might be fairly readily resolved if you would like to.
Oh, that's a good idea. Okay, I like that. Although technically you're supposed to get an approval of changing the order of the agenda at the outset of the agenda. That's according to Robert's rules. But the lawyers aren't here today. So, Tim, if you're okay with that, we're going to move on with some simpler items. Is that while they're counting ballots? Is that okay with you?
That's fine.
Okay. Then let's go to item 8, which is an item as to, and by the way, 8 and 9, I put those on for the very simple reason that there were a number of people in the public who requested this, and all I'm doing is respecting the request of the public. Just to let you know, I don't have a bone in this fight. The number 8 is what contact information do we put on the web page or the website for the public to contact us? Discussion. I open it up to board members.
Mr. Chairman, if I can add some action that we've taken
Sure.
to date is we have added to both our contact us page on the website as well as the board member page, the general email for board members. which that does go to Jessica, and then she, when we get those, anything that's directed at the board, we send out to all board members. We can certainly add individual email addresses on the Board of Health page if that's what the board would like to do. But at this point, we've added additional means for the public to comment, but we can go individual board members as well.
Well, I appreciate your saying that. Okay, duly noted. Any other comments?
Well, I mean, if communications are going to her already, and then she's passing on, I don't think that we can do something for triplicate our communication methods, so that's seemingly adequate. I don't think we should do.
Okay, duly noted. Any other comments?
This is, oh, sorry. This is Peggy. I couldn't hear what Dr. Johnson said. I don't know if people are using microphones or not, but could you repeat?
It was already turned on, and I turned it off. My apologies. That if Jessica's already receiving emails and then forwarding them to us, I don't think we need to multiply the methodology and have duplicate or triplicate. If that's reaching us, if those communications are reaching us, I think we can just, I'm fine with just one methodology. So
I agree. I agree with that.
Okay, any other comments?
And I think that our current communications are adequate.
Okay, duly noted. Any other comments? Okay, so I'll tell you what, Dr. Johnson, you want to make a motion that reflects your sentiment?
sure, since there is apparently adequate access communication to the board members as a whole, that we should maintain that methodology of communication and perhaps publicize it more if the public feels that it's been inadequate in the past.
Now, if I may take the opportunity, I think Eric indicated that he has published it. It is more conspicuous on the website.
We've added it in two locations where it didn't take place.
Okay,
Okay,
good. So then my
so
motion would just be
So
to
I think
maintain it.
he's reflected your sentiment there.
Yep,
Am I
good.
interpreting you correctly?
Yep,
Okay,
okay.
is that your motion?
Yep.
Do I hear a second? All right, we have a motion and
I'll
a,
second that.
okay, well, we have 2 seconds. Wonderful. Jessica, can we have a roll call vote? I'm trying to make the lawyers happy.
No further discussion?
Oh, I'm sorry. Any further discussion? Okay. Roll call vote?
Chairman Fletcher,
Yes.
Bonner
approve
County
or agree.
Representative Glenn Bailey,
Yes.
Kootenai County Representative Duke Johnson,
Yes.
Commissioner Bertling,
Yes.
and Peggy, sorry.
Yes.
Melissa doesn't count yet, so.
Melissa not on?
We have to get.
Yes.
Oh, you got a point there. Then we have approval. Okay. All right. Now we're going to go back to item 6, which is the vote tally for the Shoshone board member. And the tally is 13 yays and no nays. So, Melissa, you are a board member. Congratulations.
Thank you.
All right. Moving on, let's move to item 7, the strategic planning meeting. You may have noticed that there is a draft of a proposed meeting. which is on behind tab 3. I open the matter up for discussion. No discussion?
Go ahead, Eric.
I just, Mr. Chairman, just clarification on a few points. I know in the last meeting, the board had requested public comment being provided in writing prior to the meeting or at the meeting. I guess I welcome.
Are we talking about this meeting? Or, I'm sorry. go
Sorry,
ahead.
did you say we're discussing the May 10th meeting?
Yeah.
Yes. So when we were the board was discussing public comment, were they not discussing receiving that in writing prior to the meeting so that they could take it into consideration? Because I think that's partly how it's written in here is reading of written public questions and comments. I thought that there was discussion on public input at the meeting.
Are we talking about this meeting or the
No,
May 10th?
The May
meeting?
10th meeting.
Oh, well, there's two opportunities for public input. One of them will be in writing, and the last one would be an open mic.
And my question to that is, how would you like us to facilitate solicitation of input from the public?
Well, by both of those mechanisms.
And so in writing.
Or you'd have little cards or something that people would write a question on, or a topic or whatever. I'm thinking you would give it to Seth Grigg, or I could take it, or you could take it. Somebody would take those questions, collate them, because my hunch is there are going to be a lot of duplicates. Then that just represents effectively one question. Seth Grigg would ask that question, and then the participants of the strategic planning meeting would know that that is a question to address at some point in the discussion.
Okay, and I guess one of the thoughts that I had is written comment only available for folks that show up in person, or are we going to request a wider net?
Oh, that's a good question.
Yeah.
Okay, well, that's something we can talk about right now. That is a good question. I have a strong opinion as it relates to verbal questions. Only people who show up, not Zoom. If you want to say something, go to the meeting. I have a strong opinion about that. Now, as for the written comments, that's a good question. I suppose theoretically, you could start taking questions beforehand and collate them. My hunch is that there's going to be a lot of duplicates.
And Mr. Chairman, just to clarify, are we seeking questions from the public, or are we seeking comments from the public?
Well, in some regards, there's a lot of overlap there. If you're going to make a comment, it begs a response. So it's almost like a question. If someone says chemtrails, for instance, if I hear that again, I might have to commit suicide. But if, that was a joke. But if they say the word chemtrail, is that a comment or is that a question? It means talk about chemtrails. You see what I'm saying? And we'll make a comment. We have no jurisdiction. I mean, that would be our answer. It's out of our jurisdiction. Next issue.
Understood. I guess my understanding of public meetings is typically certainly the public provides comment or their thoughts on how a board or a body should proceed, and we certainly should be taking that and inputting that into the larger discussion. But is that the intent of this questions and comments period, or are there going to be questions read and then board or board members going to be, is it going to be a Q&A session or a strategic planning meeting?
I would use the initial set of questions as material to stage the conversation, the strategic planning. I would not answer each and every one of those. I would say, okay, here is a topic that is of interest to the public. There we go. We duly noted, it will be addressed. Then, for the more, if you will, dialectical component, it would be at the end where then they speak and where they vocalize.
Okay.
I'm looking for the reading of questions as a way in which to capture topics. They don't necessarily need to be answered in real time, or for that matter, even answered at all. I mean, it may be someone making an erroneous topic that has nothing to do with the subject matter of public health, in which case we ignore it. But it's a mechanism, it's a methodology to capture relevant topics on the mind of the public. That's all that's intended to do. Now, if you have thoughts on the matter, or Glenn, if you have thoughts, if other people have thoughts on how this should be handled, no pride of ownership here. I'm just,
We do have a comment online. All right.
okay, sure, shoot.
Oh, I just have a question of, is this going to be strategic planning or is this going to be a town hall?
Well, that is an excellent question. Or is it even a workshop? I have to confess that the lawyers altered my thinking about all of this at our last board meeting. Whenever I have participated in strategic planning meetings, the intention and the methodology of the meeting was of a sort that had a more extemporaneous quality to it. You would brainstorm, and you would sort of aggregate ideas, and you would prioritize, and you would push the envelope of what is possible. Now, the lawyers sat in the chair over there at the last meeting and said, well, you know, in Idaho, we have to follow these open meeting law rules. That means you have to have a specific agenda, specific topics, specific items, and it all has to be put out so many days before so that the public knows what to expect. And I went, oh, okay. Then I spoke to some commissioners about this. And in fact, that's what all the commissioners, that was the feedback I got. So your question is very germane. Are we talking about a town hall? Are we talking about a strategic planning meeting? Or are we talking about a workshop? In Thomas Fletcher's dream, I would like a strategic planning meeting, but I'm not sure that's doable. I think, so let's call it a town hall or call it a workshop. Actually, that's what most commissioners are referring it to as, a workshop. So what we're going to do is take a topic and drill down on it, and then report back to the board the thoughts of said workshop. Does that answer your question?
So we're calling it what exactly?
A workshop.
So it's not really strategic planning.
Well, I suppose it's semantics. Given the rules of open meeting laws, you have to, if you're going to have a gathering of people, elected or quasi-elected, as I guess we are, they have to follow certain rules of decorum, of how they can speak, what they can speak, etc. And so in the common sense notion of a strategic planning meeting, we can't really have that. So call it, did I answer your question?
It sounds like it's a workshop.
Yes, that's a correct statement. It's a workshop. Which is why on the piece of paper on right behind tab 3, I have so labeled it that. Panhandle Health District Workshop on Clinical Services.
The point that I think is interesting is that some of the comments that we've had from the public, I think have been very insightful and important. It's hard for us to be in a position to estimate or judge what the health needs of everyone in North Idaho are on our own, but to get the feedback from people is valuable as far as taking steps forward. I think their comments will help contribute to a better functioning, better utilization of the clinic. Somehow, my impression is that we're not maximizing the utilization right now, and they'd help us find out why. So
Okay.
I like the concept of public comment, of whatever we call it.
Mr. Chairman, if I could add to that sort of speaks to, as well as what I'm getting at is in written comment is when we notice this meeting, if we provide an opportunity for individuals that may not be in attendance to submit comments, we'll probably reach a broader audience than individuals that will either attend in person, and then I have a follow-up question on online participation.
Mhm.
But
Duly noted, and I appreciate that, and I would be in favor of that. Sure.
And another item, just to do point, and I know I sent it out a little bit late, but the health district does conduct a community health assessment every 5 years, where we do have it is a fairly comprehensive effort that does involve input from local hospitals, community entities, and so forth. So I think that as we move forward, that's definitely a document to consider as we have this discussion.
When was the last time that was done, Eric?
Much of the data collection was done, I believe, between August of 2023 and February. I believe a final report came out in January of 2024. So it's, in some respects, it's current, but I also think that in other respects, it may not reflect some of the changes that we're seeing in healthcare or healthcare funding from the state and federal level.
Right.
So.
Well, and that's where I think we're Seth's contribution. There have been some changes
Agreed.
just with this session that he's going to have insights
Absolutely.
that would help, I think, kind of catapult our understanding rather than in a simulation over a year.
I agree. No, I certainly agree. There's quite a bit of data or information I think that makes sense to consider.
Good.
Yes, sir.
Mr. Chairman, excuse me. As far as Idaho legislation development since last session, I know that they've extended postpartum coverage, so that would be a topic of discussion. How is that going to impact services provided by our health districts? In other words, House Bill 633 extended Medicaid coverage from 60 days to 12 months, specifically for postpartum care. I don't know what impact that will have. I think it will be a topic of discussion. Second thing.
It'll be in the top 5.
Yeah.
We'll put it up there.
And Medicaid work requirements and managed care. That's huge. Okay? That's been signed by the governor, and the state of Arkansas has already implemented a similar legislation, and it's evidently there were significant coverage losses due to administrative complexities. And if our legislation was based on what Arkansas did, then a lot of people are going to lose their health care coverage. Are they going to turn to their health districts to supplement their health care coverage? Because it's not getting cheap. So that's another area of discussion. The federal level, we proposed budget cuts massively through Medicaid, Medicare, reduction in the funding mechanisms at the federal level, because they're trying to cut way back. They've got to cut way back. And there's expanded coverage for obesity medication. So, in my opinion, things are still developing at the state and the federal level. So this, I think, will be a good opportunity, this stuff coming in, because he's got a lot of knowledge at the state level, at least. And, yeah, it would be a good opportunity to discuss those things. But it's not going to be for quite a few months, I would think, till we see how things develop as a result of the legislation that comes. But, yeah, this is a good starting point.
Okay, duly noted. Any other comments?
Oh, I did just follow up on the one item. Because this is going to be at Kootenai County, is it the board's desire to have a live stream or an online participation component to it?
Okay, so I have asked a lot of people that question. And I'm just one opinion, although I have actually collated enough. My opinion is predicated on a number of other opinions, so just to let you know. And I think I alluded to this earlier. It would be okay to have passive YouTube or Zoom or whatever for a broader audience, but not active. That is to say, if people want to be actively involved, they have to show up. Devin?
But I also think we need to limit the time because they're.
Oh, totally agree. Okay, so in that regards, Glenn, you will notice that the active participation component is at the end of the day. That's deliberate. Okay? Okay, it's at the end of the day, and quite frankly, if there are some of you that are busy and you have the rest of your day to deal with, I suppose we could sort of adjourn and then let people continue to talk. I don't know. I'm not a commissioner, and I don't know the rules of open meeting laws well enough to know if you can kind of send people home who want to go home or let them go home, but then continue to allow the public their cathartic, their catharsis. Because there's value in, people sort of speaking their mind. I believe that. But to answer your question, I put the public comment component at the end precisely so that we don't get filibustered.
Okay, and I would suggest that we also include next meeting timeline based on our discussion and how things are developed. We need to.
Well, that could be part of our discussion. You're saying actually have it as an item?
As an agenda item.
Oh, okay, I can buy that.
Would be
Okay.
so that
May I make a suggestion? We're going to need a motion for this. This is just an invitation for you. I'm not putting words in your mouth. But if you were to have a motion that we move forward, it would be to have then this addendum you've discussed. That is to say,
we modify the agenda.
we modify the agenda to have a future date. In other words, let's already program it that we know we need to do this more than once. The next step. And in that sense, by the way, because a lot of commissioners gave me pushback and said, okay, Thomas, what do you want to do? What do you want to accomplish? And I have to confess, I was flat-footed because I don't actually have a specific agenda. And I mean that, I actually don't. But what I would like to do is have a mature conversation as to the options that are available to us. How do we move forward? So in that connection, Glenn, I like a lot what you're saying because what it does is it cues us up. It sets us up for, okay, we've talked about all these things. We're going to see MAHA come into maturity over the summer. I mean, already Kennedy is saying a lot of things, doing a lot of things. He got a standing ovation in his press conference at the HHS the other day. So, I mean, there are moving, this is a dynamic moment in public health in America. I think that's true. Commissioner Korn, you have been polite and have raised your hand a couple of times.
If I could just make a suggestion, I'm not a very techy person, but I believe on Zoom, you can type questions in and not necessarily put an icon and be verbal. If that might be made available, just as if you go there in person, adding it down on a card, there could be a moderator that can be collecting those questions and going through them and sorting out the duplicates, if you will, and all that. Because I do find that it's very important, especially with the health district here. You're representing 5 northern counties. Even in county commissioner meetings, there are people in the outlying areas that it's just not convenient, even though they really want to participate in the meeting. It's not convenient for them to drive 30 minutes or an hour into the commissioner's meeting. And what you're doing is you're representing people multiple hours from here. And it sounds like you're wanting interaction, but you don't want to be overloaded, obviously, because, I mean, you have 1,000 people on Zoom all wanting to talk, I understand that. But I think you may want to entertain the fact that you could or would take questions, written questions from Zoom, and possibly give the public an avenue to even email your questions in advance, and with a cutoff date of that Friday before the meeting or something like that, so you guys can have time to sort them. I'm not trying to make the job harder, but I do think that we need to make sure we're representing the people the best we can, to take into consideration. And I would also like to apologize on behalf of the Bonner County Board of Commissioners for not meeting with you. I'm not sure why we didn't do that, but I think we should have personally, and I would like to offer an apology on behalf of them.
Okay, well, that's fine. This is a matter of clarification, and again, this is for open discussion. I'm asking all board members to provide input here. I don't want to be the only voice in the room, please.
Tom, if I may, I think that's a great suggestion that he made there, that if we had someone who was just solely devoted to collecting comments, I know you feel passionate about having someone in the room, and I understand that, because if someone feels strongly enough, they'll be there. But life is complicated, and yet someone could be very passionate, just incapable of getting down. But if we were able to, the more data we collect, and if there can be even 2 or 3 people that are, collecting, there's going to be duplicates. There's going to be, and almost every large session I've ever been in where they take questions and answers, they sort through them and say, okay, we've got 10 that are all asking the same question here. Let me just ask that question, and then they're collecting the next ones. And I think we'd be, I think that the more people feel that they are a part of Panhandle Health, the more it'll be a utilized entity and feel more like them. And that's good.
If I may respond to the last thing you said, one of the comments that a frequent comment I got back from commissioners going around talking to different commissioners was that perhaps one of the reasons that Panhandle Health Clinical Services are underutilized is that people don't know about it. So that plays in, Dr. Johnson, with the point you just made. Maybe let's let this workshop act as PR. Let it be PR. So actually, if we are interested in promoting Panhandle Health Clinical Services, make people believe you love them. I mean, so you see what I'm saying? So I really enjoy what you're saying there, which implies with what you and Commissioner Corner are saying is give people the opportunity to speak, to participate, then they will appreciate you. And if they appreciate you, they will come to your clinic. Is that what I'm hearing? Any other discussions or comments of any other people? Board members? Okay. Eric, should this motion pass, it hasn't passed, but should it come to happen, are you and Jessica in a position that you could actually be the collators of the written stuff?
Yes.
In real time, because it sounds like to some degree, we're going to have real time feedback from them.
And Chairman, I thought that Commissioner Corn brought up an excellent point is depending on the volume of feedback that we get, it will take some time to process it and to put it into categories for the board to consider. Real time, I don't know how many folks are going to be here. I certainly, we can't promise if we're starting to get all kinds
Jason will
of people
be there.
popping, so we can certainly, when the meeting is noticed, we can provide, make it very clear if you have comments, submit them by this date, and then we have at least a day or two that we can consolidate those so that we can.
Yeah, but the idea is even in real time, even last minute. It's more problematic.
That's more challenging.
I get it.
But
I get it.
I'm not against
Hostile
it.
to it.
No.
But you just do the best you can. It's kind of the way I see it.
But it may be best that even if we are going to consider those, we put a date on it to encourage people to.
I like that. Yes, I think that's a good idea also. Right. Agreed.
So the Cinco de Mayo is the Monday before this proposed meeting. Will give us sufficient time to review. Cut up.
Oh, I'd make it towards the end of that week. Yeah, because people aren't even going to be thinking about it a week ahead of time, Cinco de Mayo. I mean, that's my hunch. Yeah,
How much time is your staff going to need to review this and give us?
I think at least a day or two. I mean, we'll have a better idea as we see what comes in.
yeah, it's very difficult for Eric to know that. If there's 10 people, 10 comments, it's nothing. If it's 500, and you're not going to know until it happens. That's right.
But the minimum.
Well, count on me. I'll come in and help. I mean, sure. Yeah. Okay. Other board members who are participating via the internet, any comments? Okay. Anyone present in the room want to say anything more? Okay, then I will entertain a motion. Is someone willing to make a motion?
Mr. Chairman, I don't want to belabor this by any means, but we've talked about a few different things, and I just want to make it clear. So when we notice the meeting, we are going to provide an email address for individuals to submit written comment with a drop dead date. So, but then there was also discussion of passive participation, which would be our YouTube video versus providing a forum for more active, which would be, I guess, in our case, teams. Which direction is the board heading as far as the day of the meeting and public participation?
Well, your question is, of course, superb.
And if I may,
and it deserves an answer.
And if I may, Chairman, there was quite a bit of consternation when there was a belief that the health district had somehow not provided opportunity to comment. I want to make crystal clear that whatever the board's wish is what we as executive staff implement.
Okay, I get it, and duly noted, and I respect your position there. Okay.
Yeah, I think part of the discussion was, live comments, and I think it would take a technology like Zoom or whatever where you can chat box in, but it would take one of those in order for it to become live feedback.
And Mr. Chairman, we might even need on that some sort of end time, just because once the board gets into discussion, it's going to be very hard to receive it, compile it, and get it to individuals in a matter for consideration.
Okay, I'm going to make a comment, and it can either be accepted or not. I would say that anyone who wants to put in a written request ahead of time, even up to the day where we have enough time and staff to deal with it, is acceptable. But once the meeting starts, and we go into our kind of workshop and we talk, and then we're more or less done. The hour is closing. We're approaching noon or something, and we've run out of things to talk about. We've even decided when we're going to meet again. And then we turn it over to the public, okay? At that point, and here's where I'm going to speak only for myself. At that point, I would say the only feedback we get from the public is vocally, not written, and they have to be there. Otherwise, the logistics of accommodating everyone becomes highly problematic. I mean, is this fair enough?
We'll need 2 days in advance to set the agenda, correct, for the open meeting?
Yes.
So Thursday, Friday would be the 2 days. Some of those.
You know, we might set it in the next day or two. I mean, it might get set before that, but at least 2 days. Correct.
And how much is that going to be influenced by written submitted comments? We were
Yeah, and
going to have that, the deadline. And then your staff would have to have time to consider some of those things before you set the agenda.
Yeah.
The final. Okay.
Well, I'm thinking we can set the agenda in the next week. It gets posted. There's no reason you can't post it well in advance. And when you post it, say, okay, we're taking comments. We will entertain comments and questions and topics until a certain date, drop dead date. After that, if you still feel compelled to say something, you have to come in. Does that sound reasonable?
Yes, it does.
Are we going to limit it to the proposed agenda items? In other words,
Oh, you mean our discussion?
No, I mean.
Oh, no, no, it's not limited. It's only limited by your imagination.
So contrails.
I mean, you're a board member and a participant. No, this is your event. No, I'm only okay.
That's what I'm.
The public's injection of subject matter is by written comment limited up until, say, 48 hours, 72 hours beforehand. Does that answer your question?
Yes, that is, as far as the subject matter of their comment, is it going to be limited to proposed agenda?
Oh, yeah, clinical. So we're not going to talk about chemtrails.
Okay, that's.
No, I mean, we have to.
We have to limit it.
No, we have to limit it. And that actually, if, you know, I sort of made a confession earlier that I was left flat-footed because I was thinking of a strategic planning meeting in a free-form sense. Well, you can't do that. But, you know, there may be a wisdom there. There may be and the wisdom is you've got to have some discipline. So we're just going to talk about clinical services. That's it. We're not talking about DEQ. We're not talking about septic, or we're not going to talk about waste disposal. No other topics. Though I think those other topics are interesting and need to be talked about, but not this workshop.
But I would have further comment on action item number, no, it's not action item. Under Seth Grade Facilitator, item number 1, impact of recent Medicaid legislation.
Uh-huh.
I would like to see that expanded to at state level, this at federal level, this.
Oh, wow. Okay, now that's an excellent question. When I speak with Seth, I'll ask him how encompassing he's willing to be.
Because that's pretty broad, the impact of recent Medicaid legislation.
I know, it's big. And I left that deliberately vague because, to be quite honest with you, from my perspective, that's a black box. I'm saying, Seth, take it over. As a matter of fact, from when Duke and I are going to, I mean, the three of us are going to give some short little lectures, basically to stimulate ideas. Just here, we're going to throw out ideas just to get people thinking. All right, after we have thrown out ideas in short, 15, 20-minute lectures, then we invite Seth up to the front and it's his show. That's kind of how I'm looking at it. He will have already been programmed by knowing what these written questions are. So he's going to have a stockpile of topics. He will have just finished the legislative session. He is going to have some grasp of what at the state level are the consequences of the Jordan Redmond bill and other moving parts. Now, as far as federal, I mean, I don't know. I mean, I guess I'll leave it up to him. I don't know what his comfort level is. I don't know what his knowledge base is, and I'm not going to speak for him.
Because
We don't know.
Federal level, they're trying to limit
All kinds of things are
funding
right.
for a lot of things.
Right.
How's that going to impact on?
Look, we don't even have a bill from
County.
Congress.
Yeah.
Everything you're saying is true.
Mr. Chairman, we have another comment on virtual.
Yes.
Peggy.
Oh, yes, Peggy.
So since we're mainly discussing clinical services, and maybe I need to ask Eric this, are we hearing from clinical staff? Is that something valuable that we should be taking into consideration? And maybe people on the board have a broader knowledge than I do, but I'm just trying to understand if, the people that work in clinical services, is it important to hear stories from them about how they impact life?
Well,
I don't
Eric
know.
is.
I'm just throwing that out there.
Yeah, and I thank you for asking the question, and it's a superb question. You'll notice that heading up the whole morning is Eric. He is going to give us, and how he does this, he may bring some of his senior staff in to talk about it. He may do it himself, but clearly the answer to your question is we have to hear from the highest level of administration of Panhandle Health what's going on in clinical services. So your question is superb, and I would leave it. I would entrust our director to handle that in an appropriate fashion. Eric?
Mr. Chairman, I certainly agree with that. It would certainly be helpful if there was some general idea of this number 3 item options and direction of public health clinics. Be helpful to know what the thoughts are there in order to respond or be prepared to respond, know what staff would be appropriate to participate.
It's a great question, and the three of us need to caucus. That needs to be flushed out. I couldn't agree with you more. But the 3 lead lectures need to be coordinated, is kind of what I'm hearing you say. And I totally agree.
Yeah.
But at the same time, they need to be coordinated, but I don't want to sort of have a cafeteria style format where here's your limited number of options. I also want this to be, throw out ideas and let people run with ideas. I mean, my favorite idea. I'll just throw mine out on the table right now. We need to consider food as medicine in the sense of the Weston Price Foundation. I just read an article that there's a professor of psychiatry at Harvard who has a 50% successful treatment rate with schizophrenics, full-on schizophrenics, by changing their diets. There are programs of juvenile detention centers in this country that are achieving phenomenal success of acting out in violent behavior by modifying diets. Folks, I think we're missing an opportunity here. I mean, I'm sharing with you Thomas Flusher's favorite topic. Now, is that the only topic out there? No, but but we'll coordinate. I mean, we'll flush it out.
Yeah.
Have ideas.
General concept.
Yeah, sure, of course.
I mean, and that's how I've always interpreted that terminology of options for directions. I mean, it's just ideas and options, not much beyond that. And based on, your reports, based on what is and isn't being utilized. I mean, or let's come up with some other ideas. I mean, it's just, that's where my thinking has been.
And Mr. Chairman, I think that to the point that Glenn has made very well is, and in my thoughts, and I've expressed these before, is where things land at the federal level are going to have a significant impact on what the needs of our community are and how we can best respond to them.
Mm-hmm.
So, certainly here in May we can come up with some general concepts, but I think that the rubber's going to hit the road here later this year.
Well, also too, though, usually within funding mechanisms, there is some leeway and options, and sometimes if we just knew what the needs were, we can help direct them in the direction that's most apropos for our local area. So, but we won't know to direct them unless we have the feedback, and so that's. I don't think we always have to be in a receptive, passive mode, but more proactive. And let's say we were proactive as heck, great need, and absolutely no money available, then we just sit there and chomp at the bit until it is available. But at least we knew where to put it when it comes.
And we have additional comments on the chat.
Okay, Jessica,
It looks like she's disconnected now.
do what?
It looks like she's disconnected now.
Okay, so she writes that and then disconnects, is that?
That or she logged off, but she's no longer on Teams.
Okay, I don't,
Does she
okay.
have, does she need to request permission to rejoin?
Yeah,
You
she's
approve
back.
it?
She's come.
Jessica, are you back? I don't know how to deal with this. Can I get advice from other board members as to how I should deal with Jessica's comment? I think I have asked for other people who are not here to speak several times. Is that fair?
Mm-hmm.
So are Duke and I commandeering the meeting? I mean, is it only us who's been permitted to speak, or have I in fact invited others to speak?
Well, I, as a board member, I have no idea what you guys are going to speak about. So I kind of agree with what Jessica's saying. I mean, we sort of have, been down this path before where I don't think, the decisions were made as a complete board. So, I mean, I get what she's saying, and I don't know the content that you're actually going to discuss.
What's in regards to the proposed agenda, when you say Thomas Fletcher did here? I think she
Well,
wanted-
but I'm not, let me assure you, I'm not going to be making specific recommendations. I'm going to be asking questions and providing information as substrate for stimulation of thought. So when you say Thomas Fletcher doesn't speak for the board, I agree. I don't speak for the board. My intention is to provide information and a way in which to think about the issue at hand. Now, Peggy, would you like to give a lecture that morning? You're invited right now.
No, I'm going to defer on that because we've gone from being strategic planning to now we're a workshop with a similar format to a town hall. So, at this point, I can give input, but I am not going to do a lecture. I do think, I think the board needs to be just clear again that, when boards make decisions, they're collective decisions. We can all have opinions as individuals, but as a board member of Panhandle Health, my understanding is it's the board collectively that makes that decision.
And of course you are correct. I would only point out that we're not even making decisions at this workshop.
Right.
We're not even making decisions. It's a conversation.
Yeah, I think there's a completely fundamental misunderstanding, especially when it's all in capital letters there. There is not a position going to be taken. It's questions going to be asked. How do we meet the needs of the community? What are some potential directions we can go? What are some ideas? That's not a position. That's an informational gathering session. It's allowing feedback from the community for us to meet their need. I'm rather surprised that somehow that's being interpreted as a position. And that's an unfortunate miscommunication apparently on my behalf. That's not my intention at all to be making statements or positions, but rather fact finding. That's why the public is involved. That's why questions are going to be asked. How can we better utilize our resources based on the funding that's available? What steps can we take? Or should we just be silent and do nothing and not communicate and just keep the underutilization as status quo? I don't think that's good for anybody. So this is not a position. This is a informational gathering session. So I'm sorry if
And if that's the case, yeah, Duke, I think if that's the case, that's wonderful. And Peggy and I are, of course, all in favor of that. But you have to understand a little bit of the reticence because I'm just, it's not entirely, I just don't know what anyone's going to say. And so I get a little bit nervous that there are going to be statements of.
nervous of what? I didn't hear, Jessica.
I think, as Peggy said, from sort of past experiences here, that I just get a little bit reticent. The capital letters were not meant to be sounding like yelling, although that is how they come across in text. I realized that, and I was in a position where I couldn't get my audio to work. But if we're fact finding, if we're asking questions, I think that's fine. I have no concerns about that. But I just, not only in this meeting, but just in general, I just want to make sure that when we're out facing the public in any way, shape, or form, that we're very cognizant about the fact that we are in a position by being on the board where people can make easy assumptions that maybe this is what the board thinks about XYZ. And so I just think we have to be cognizant of that.
Well, I understand, but I think that you can take my words for face value. It is informational gathering. There's no reason to be uncomfortable.
And Mr. Chairman, I may be incorrect, but some of those concerns may stem from, various public meetings that you've been in attendance with and comments that have been made where it may be construed that that's the board's opinion, where in fact they're more your thoughts. I don't know if that's been made explicitly clear to the community at large. But I don't want to put words in anybody's mouth, but I think that is.
Are you referring to me?
No.
Oh.
To the various meetings that Dr. Fletcher has attended, radio shows and stuff.
Where, yes, but it has been made also aware, or that the board has yet to make a decision.
Right, no, I'm just emphasizing that
And I have gone out of my way when I speak publicly that I am speaking for myself and not the board. I say that over and over and over. So the accusation that I'm speaking on behalf of the board is false.
it's not an accusation. I'm simply saying that the perception.
Well, then the perception on some people's part is incorrect. I go out of my way to say I'm speaking on my behalf. Every single time. Okay. Is someone, is discussion, I mean, I'm happy to keep talking about this. Anyone else want to make a comment? Is there someone willing to make a motion?
Mr. Chairman, again, not to belabor this, but just to be clear, as far as reception or solicitation of public comment. So are we talking midnight Wednesday, the Wednesday before the meeting? So that gives us Thursday and Friday to compile any written comment in preparation for the meeting. Is that the board's wish?
Yeah, that seems like 2 days is plenty of time.
Okay. And then the final point of clarification is the day of the meeting, are we providing just YouTube, or are we providing a link to Teams so that individuals can log in and participate at this item for this end of day public comment period?
Oh, only YouTube. Only passive.
Okay, so only passive at the day of the meeting, written comment up to midnight Wednesday.
Correct.
Okay.
Sure.
I thought I heard Glenn say that the agenda may not be available until potentially 2 days before the actual meeting. If we are doing an agenda, does that have to be board approved? And if so, is 2 days prior enough time to have the entire board review and approve the agenda?
This is the agenda.
So this is the finalized
This is
agenda.
it.
Finalized agenda here.
Well, I guess there may be a friendly amendment. He's going to add a friendly amendment, and that is future dates. So why don't you make the motion with the friendly amendment?
Mr. Chairman, one point of question is that as far as attendees, I see the commissioners, the board, the director, and executive staff, and so if that's the board's wish that then are you directing us to send out invitations to all of the county commissioners? Is it the board's wish that all county commissioners attend? We certainly will have representation from some that are on the board, but are we formally inviting all sitting county commissioners?
Oh, that's a good question. What do you think?
I think it's a great idea to at least invite them.
Okay.
And, don't want to beat this to death. My thought is I see a larger conversation at some point down the road where I would welcome, I don't want to get health district fatigue, because I would certainly want their opinion and want their input as we have more concrete information on federal funding and the federal stance. I don't know if it would be more valuable to have board and executive staff largely in participation for this shorter meeting with an eye toward greater participation at a later date, or if we want to try to invite them now and at a later date. So I just pose that to the board.
I didn't understand, Eric. So you're saying not invite them for this meeting, but invite them for a later date? I'm sorry, I didn't understand.
Well, my thought is that this upcoming meeting, we can certainly discuss the future where opportunities may exist, but the reality of that will likely be some months out. You know, the federal funding is a huge component. You know, half of the district funding, significant Idaho funding, Medicaid funding. If we want to get into the, really specific about the best use of the health district and county support, I think that's when that conversation will be most valuable, is when we have that information. This conversation here certainly can be valuable from anticipating general information, getting set. But I want to make sure that if we're inviting the county commissioners, that it's have something very, very concrete to talk about. And I'm not saying that we don't. But.
My take on this would be to regard the county commissioners as adults. Invite them. If they want to come, they come. And if they don't, they don't. And it's okay. And I received, in fact, that whole spectrum of feedback. Some felt like it was a worthwhile exercise and they might show up on a Saturday. Others thought, I'm not going to take my Saturday out to go talk with a bunch of, public health geeks. So they're not going to come. And that's okay. That's perfectly okay. I would send them a polite FYI, we're having this. You're welcome to come and participate. They're adults. If they don't want to come, that's fine.
Thank you.
Yeah, your idea that this is preliminary and there's going to need to be a follow-up is, I think, spot on. I mean, this is just almost a fact-finding session, so there's not going to be true distribution to any great degree, but just rather than just being a boat floating in the water, it's like let's put our sails in a direction that seems to respond to the needs of the community, and then we'll find out how well the winds blow when the money comes in. So I can see, there will definitely be a bigger one.
And if we end up going in a completely different direction or something that's novel, it may be useful if you front-loaded the commissioners so that they have a heads up, so that they were at the table in the conversation. I think that's only a polite thing to do. Remember, we're not making any definitive decisions on purpose. Again, I would treat them as adults if they want to be a part of that conversation.
Because the final fiscal year is October. So, I mean, if we had something, a couple of months before, then that would help direct their ship as well, how they want to distribute.
It's an interesting time right now. On Tuesday of this week, the directors had a call, the first call, frankly, in a couple of months with the Division of Public Health and Health and Welfare. And they are still sorting out the outcome of the most recent legislative session and what that looks like for funding mechanisms. So, which is a little concerning because here we are, in April, and usually most contracts, we're seeing drafts or we're reviewing them here in short order. And so in my opinion, with health and welfare still figuring things out, there's just a lot of unknowns on the health district right now.
And there always will be.
Well, I would argue that at this point in time, a few more than we typically see.
Okay, fair enough. Any other yes?
So despite the unknowns and despite what your budget is going to be for the upcoming years and all that, I don't think that really changes what the public is needing or asking for from the health district, from their clinic or anything else. I think it's very valuable that you guys learn and collect that information from the citizens. What are they looking for in their Panhandle Health District clinic? And then at least you've already done the preliminary planning, if you will. You have the information from the people, what they would like. Now, once you get the information on your budgets, then you guys can decide what you can and can't do.
public comment, absolutely, all day long. I am by no means implying that we will not, we're trying to impede any sort of
Right.
public
And
comment.
I agree, if I don't commissioners, then I think you have to comment on them. It's better to let it be on them than let it be on you, say, well, we weren't invited, right? Get rid of that, pass it on to them.
Okay?
Yeah.
Did you want to make a motion?
Yes, Mr. Chairman.
I second, no, I'm sorry.
I would make a motion that we expand item number 1 under Seth Grigg facilitator to expand with state and federal legislation that has been recently approved and passed. Regarding Medicaid grants. And then we add item number 5, discussion, an action item, discussion and motion on the next meeting date. And proposed agenda item include.
Okay.
I'd like to second that.
Okay, but before you go, can
No.
I ask that you do one more friendly addition, since you're in the addition mode? And that is number 2, Seth Grigg facilitator number 2. And that is that the written comments that the period of closure will be 48 hours before the meeting. That was at the request of Eric.
Thank you.
And I would also propose that item number 2, that the deadline be 48 hours prior to the proposed meeting. Held on 10 May, 0900.
Thank you. Any other friendly amendments? Okay, hearing none. Do I hear a second?
Yes, I'd like to second.
Okay. Jessica, roll call vote, please.
Chairman Fletcher,
Yes.
Vice Chair Jameson.
Yes.
Dr. Johnson,
Yes.
Glenn Bailey,
Yes.
Peggy Cavala,
Yes.
Commissioner Bertling,
Yes.
Commissioner Cowles.
Yes.
Well, thank you, everyone. The next item on the agenda for today is, we went a little bit out of order. Contact information. Oh, okay, virtual platform. Again, this is a topic that the public brought up at the last board meeting. And all I'm doing is just acting as an appropriate steward. I'm bringing the topic forward. How do we want the public to interface with this meeting? We're not talking the May 10th meeting. We're talking this meeting moving forward. And I open it up for discussion.
Mr. Chairman, if I can just share, we did a little pre-work on that as well.
Uh-huh.
Jessica and Kate looked into it. Our team's application would be able to accommodate individuals if they wanted to attend remotely. There will be a few logistics simply because they will show up similar. We will have lots more boxes up there. But that is something that we do currently have the technology to do. What we would propose is we could have that link on our agenda as well as our YouTube if folks just wanted to watch passively. So again, something we can certainly accommodate. It's just a matter of it'll be a little add a few challenges to the meeting, but certainly if it's the will.
Is there a cost impact? No cost impact, okay? Any discussion?
Mr. Chairman, I just had a question on the team's application. Is there a way to designate board members so that they could be at the top of the list?
They wouldn't be at the top of the list, but I can spotlight whoever's talking. That way they would pop up on screen. And I would be able to make board members co-hosts, and that would give them the option of speaking as well as putting comments in. If I did that just for them, public would not be able to use the chat. They would only be able to talk during your public comment session.
Okay, so there is a way for you to suppress their
Yeah,
ability to speak
yeah.
during our discussions.
Yeah, there's a way to mute them, disable their mics, disable their cameras, and
Until the public comment period,
correct.
then they
Yes,
have
yeah.
that.
Any other comments? Yes, Commissioner Corn.
I'm the one who's talking here, but I just had a question. So are you, like on Zoom, if I were to attend virtually, I raise my hand, such as I'm asking to speak right now, and can I raise my hand as a citizen, member of the public, and then possibly, if there's discussion, you recognize to speak on a subject matter or not?
I guess his question is how do you know he wants to speak? When
They
you-
would be able to raise their hand, yes.
Oh, okay.
It would just disable the chat, I believe, because there has been previous board meetings where the public has taken over on Zoom and manipulated some of the chat as well as the cameras. And so we're trying to make sure that that doesn't happen again. So there was a little bit more control by putting just the board members as co-hosts. But yes, the public would be able to raise their hand.
Any other comments?
Okay. Mr. Chairman, I make a motion that on item number 9, virtual platform for public participating in board meetings, that we approve the team's application as our primary means of communication.
Okay, so you're proposing that we allow the public to participate.
Well, yes, this application is the focus for primary means.
Teams. I think the name of the product is Teams, right?
Right. Isn't that what the action item is? Virtual platform?
What? Oh, right. So you're proposing that we allow the public to participate in our meeting via a virtual platform.
In that virtual platform would be the Teams application.
Right, it's the one we have. It's the one we own. We don't own Zoom.
Right.
Right.
So
That's your motion? Okay, do we hear a second?
Oh, yeah, I'll second that.
Roll call vote. Well, actually, hold on. Any other discussion now that we have a motion and a second? Any further discussion? Okay, hearing none, roll call vote.
Chairman Fletcher,
Yes?
Vice Chair Jameson,
Yes.
Dr. Johnson,
Yes.
Glenn Bailey,
Yes.
Peggy Cavola,
Yes.
Commissioner Bertling,
Yes.
Commissioner Cowles.
Yes.
Okay. Item number 10. Eric, you're front and center.
Thank you, board members. I was requested to put together some data on the last 10 years of clinical services and the status thereof, which I put together. It looks like we'll probably have a greater discussion here on May 10th in this, but so this is, I guess, a bit of a precursor. But this largely consists of slides with data. So I would certainly welcome any questions as we walk through this. So just a few terms to get this meeting or to get this presentation started. You'll see these as they come up in the charts. Children's immunization is going to be pretty self-explanatory. I'm not going to read that to you. Adult immunizations, sexually transmitted diseases or infections. This is the treatment and counseling that occurs with that program. Family planning. Again, I think this group, I don't need to read the definitions on that. Care Plus, just to clarify, that is the primary care services that are provided here at the health district. That frankly covers a fairly comprehensive number of treatments and diagnostic work that's done here. And then Women's Health Check is a specific program, Medicaid federally funded program through Health and Welfare that provides for cervical and breast cancer screening at no cost to qualifying women. So here is the chart of the last 10 years broken down by participation, clinical visits in that program. The red line that you can see above is clinical staffing over that time frame. The table below shows specific numbers. And then I put a line in there for when Medicaid expansion took effect. It's fairly self-evident that Medicaid expansion had a significant impact on our services. Just to clarify too, I did remove flu immunizations from that so that they wouldn't skew the numbers. Those are usually done in the fall. Some of the numbers can be fairly high. So this really does a better job of representing clients that we are seeing in the office for medical services. Yeah.
So overall, what kind of a percent would you say that would be on the decrease?
I have. Well, I think if we just look at actually, I have a slide coming up that'll show that up, but okay. It's a significant decrease. There's no doubt. One of the things that I do want to clarify on this is, and you'll see it a little bit later in the slide, is while FY25 it shows projected as 6, we have 4.5 medical personnel on staff right now. And to clarify, we have 1.5 nurse practitioners or FTE worth of nurse practitioner, 1.5 nursing staff, and 1.5 medical assistants. So we are at a bare bones crew right now. Some of the numbers that you'll see coming up for the last 2 years, in part, are reflective of likely of folks being able to secure services because they qualify for Medicaid expansion or Medicaid. Some of it, though, is going to be reflective to the fact that the market for clinical staff, medical staff, is exceedingly challenging right now. There's a finite number of medical providers available, and Kootenai Health. There's some big dogs that we're trying to compete with: Kootenai Health, Northwest Specialty, even Heritage Health. There's significant demand for these positions, and it's a challenge. So this is just another way to represent the numbers before. What this does is this concentrates the years by program, by category. So you can see we had fairly stable program activity in pretty much all categories, some movement certainly. But again, the blue line represents Medicaid expansion, and you can see downward movement in most categories. One area where you do see increased services is in Care Plus, which again is the primary care services that the health district provides. And frankly, I think that why you're seeing some movement there reflects the community health assessment that speaks to limits in access to timely care. I think a statistic that report shows is, I think it's 1 in 3 individuals do not see a medical provider because they can't get an appointment in a timely manner. So I think that that's reflective of a need in the community. Again, I think that a lot of the other reductions are reflective of individuals having being able to see providers in other arenas. Because again, let's be honest, the clientele that we have are going to be the individuals that are either uninsured or they're have limited income streams in order to secure services at other locations. This is simply a representation of, I was trying to present representation of the work that the health district is doing in as many avenues as possible. This takes a look at the time spent. So as you saw, some years ago, we went from 15 staff to where we're at four and a half staff at this time. This shows percent of time on what our staff is actually doing. Now you can see where the bulk of our time is spent in primary care service and family planning. That's the vast bulk of the time that our staff is spending. Any questions as we roll through this? There's not a whole lot of slides, I'll be honest with you.
Could you explain a little bit more on Care Plus service? What constitutes that?
Sure, and that, frankly, that's primary care. If you have a cough, if you have a cold, if you have a sprained ankle, I mean, pretty much prior to, and Peggy might know this, prior to 2013 or 2014, the health district primarily lived within family planning, STD, immunizations, that world. And I believe when Don Duffy came on, he expanded the programs to include primary care or pretty much, any other. Yes, and that's where we have seen growth in that area. That's kind of a general explanation, but it's a bit of a catch-all primary care category. So I've already alluded to this. What we're trying, and we're trying to be good stewards of the money and still recognize that there is a client base that we're trying to serve. So you can see we've had a significant decrease in demand for services. As I stated before, some of the decrease in numbers is reflective of a difficulty in keeping qualified or medical professionals on. But from the high of 15, at least 10 years ago, we're trying to keep 6 staff on. That's 2 NPs, 2 nurses, and 2 medical assistants. And where we're at today is, as you can see, the numbers up above. We are at a bare bones staff. I can tell you that I spoke with, as you know, Jenna Dow has departed the organization. I've spoken with our clinical staff. Our NPs, they are seeing clients every 30 minutes to an hour. So it's not surprising that the other thing I guess I want to note is this comment at the bottom. We are sending the limited staff that we have out to outlying offices to provide services. So we are not a private clinic where we have multiple providers and we have stacked lobbies for folks waiting. I mean, if we have one nurse practitioner on board in the Hayden office, and I mean she's going to see somewhere between 10 and 16 folks. That over an 8 or 9 hour day, that's not going to have a whole bunch of folks in the lobby. So that's the current status of our staffing now.
Yeah,
so again, we've already talked about a number of these items, but these are things that I think are important for this board to consider as we look forward and as we have additional conversations about clinical services here at the health district. Is our primary care services are growing, and I think that is a demonstration of need in the community that's reflected in that community health assessment. The additional criteria on Medicaid expansion. I was reading an article earlier today that was, again, I think Len brought it up. We've modeled ours after Arkansas. That they talked about how I think these additional, the additional requirements that the state of Idaho took on will likely mean that 1 in 4 individuals will fall out of Medicaid expansion. So we, and I guess the final point here on the bottom is again, this sort of large unknown of what's going to happen with regards to Medicaid at the federal level, what's going to happen in regard to funding, human health and human resources, or health and human services programming. We don't know what we don't know at this time, but I think that it's fair to assume that there will likely be more individuals that fall out, that become uninsured over time. And there's a larger question on what, if any, services or what, if any, organizations are going to pick those individuals up. As you can see, there were, I'll call them free clinics. There was Bonner Partners in Care for a number of years. They folded up after Medicaid expansion went into place. And the St. Mary's Community Clinic, another free clinic, that folded up as well shortly after Medicaid expansion because, the need just was not there. So I love this slide in because it's a statistic that I pulled. I think it's based off U.S. Census, but National Institutes of Health. On the top, you can see the uninsured and poverty rates for the U.S. You can see the stats for Idaho, and then you can see the stats for our 5 northern counties. And while you can certainly say that Kootenai County and to a slightly lesser degree, Bonner County are probably, well, there's still some need, but they're certainly in better shape than when you look at our 3 smaller counties. I think that it's safe to say that when we look at changes in requirements in Medicaid expansion and possible changes in funding, that we are going to see needs increase, particularly in our smaller counties. So I really end this with some questions. So who is going to provide care to the uninsured? At this point, there are health districts and there are federally qualified health clinics or health centers. Federally qualified health centers are highly dependent on federal funding as well and Medicaid funding as well. Possibly, I mean, they're significantly larger than us, but they're also almost wholly dependent on those funding sources. I don't want to overplay the support that the county provides to us, but it's a significant amount that the counties provide to our budgets. And the question becomes, what role do we have in what may be coming at us? And what is the cost if care is not available? If the health district, had limited services or didn't have clinical services, where would those individuals go? If there's already the many communities are at capacity with primary care services, to the point that we're seeing growth in ours, where are those individuals going to go? And then I put this last question is, at what point are we transitioning from a private health matter, which your health is frankly a very personal issue, to where this becomes a public health issue. I mean, if we're seeing additional spread of communicable diseases, if some of these same programs no longer exist, what is going to be the solution, and how is that going to bleed over in the individuals that do have health care? The final comment that I want to make is in regards to what is the cost. I was looking, as I've been researching some of this, in I believe it was the 2022 legislative session, as part of Medicaid expansion, the legislature repealed several statutes related to county indigent funds or indigent fund requirements. So that safety net doesn't exist any longer. And so conversations that I've had with a few individuals are, if health districts and if FQHCs are not there to help pick up these individuals, where the care lands, which is notably far more expensive, is in ERs. And if it's happening in the emergency room, at this point, the hospitals are really left holding the bag. And my question would be, and this, I don't want to be overly dramatic, but is there a time when the hospitals don't find this palatable and they look to the feds to say, I believe it's EMTALA, I'm not a medical practitioner, where they look to the feds and say, we don't want to be obligated to provide care because it's costing us excessive amounts of money. So just to close, in my opinion, this is a much larger question. And I will even say, outside of the Panhandle health, the health districts in general, counties are seeing reductions in federal funding for schools, for infrastructure, for various other things. So counties are being pinched as well. So I've had communications with very preliminary communications with some of my counterparts at Heritage Health, but I do believe that this is going to be a community. Any solution is going to have to be community-wide. It's going to have to involve all of the providers, the hospitals. It's going to have to be a very serious discussion with, with the county commissioners on what funding they have available and how we can, where we fit, where the health district fits, where our dollars, where the county's dollars can do the most good. So that is where I see things going, and that's where I think that it's important to plan. I think it's important to have some relationships built, because I think that this is coming at us, and I think that we're going to be making some very serious decisions in this coming year.
Great, thank you very much. Would it be possible to have a copy of those slides in preparation for the 10th? That'd be great.
Absolutely, I will have.
And also, can you send a copy of your slides to all the commissioners? Many commissioners said, what are we talking about?
Sure.
Which is a very legitimate question. And so this is it. They need to have a heads up also.
Absolutely.
And then I have a question as it relates to these federally qualified clinics. I know I've seen some. There's a big one in Ponderay. How many of those are around? And what does it do? What does it take to qualify as a patient in one of those clinics?
I think you may have found the extent of my understanding of federally qualified health centers. Well,
they're cropping up.
And what I will say is, I do know that Heritage Health, I don't know if there's limitations in the overlap of the service areas that they provide. I do know that Heritage Health, they have a presence in the southern 3 counties. So Kootenai County, they have their largest location off of Celtice Way, but I believe they have a smaller presence in Shoshone and Benewah County. If you look up north to Bonner and Boundary County, it's Connexu Services, which is again a FQHC. So qualifying wise, I believe, and is it unfair to ask you, Christine? I think quite a bit of revenue they see is through Medicaid payments.
To Chairman Fletcher's question, what does it take for a patient to qualify? I don't know specifically, but what I suspect is that it is open to any patient that wants to receive their services. I don't think you have special qualifications. I have not run into that.
So can it serve as a safety net for a
You do-
subset population?
Peggy?
There are limitations if you need to qualify for their sliding fee scale. They're going to be financial. I know that. And just as far as like we have Heritage Health down in Benewah County, but they only provide dental and mental health and substance abuse. They don't provide primary care. So we have a federally qualified clinic in Plummer, and for most of the population, if you live in St. Mary's, Idaho, or you live in Fernwood, or you live in Amida, or you live even in Shoshone County up in Avery, having adequate transportation. And if you're a person that works during the day and can't get time off during their hours, it's not really an option. So, even if a county has a federally qualified clinic, it doesn't mean it meets the healthcare needs of all people.
And Dr. Fletcher, one thing if I could add, I don't know if the board recalls, but a couple of months ago, there was a newspaper article where Heritage Health had to make some significant cuts in its staffing because of budgetary reasons. I don't know the extent of that. I believe they made every effort to keep their practitioners on board and reduce administration, but I don't know if that's an indicator of some of the challenges or the changes on the funding streams or not, but I would be surprised if they're not impacted by the same things that are concerning us as we continue to monitor what's occurring at the federal level.
Okay. Any other questions? Yes, ma'am. Someone from the public wants to ask a question.
Very good care, really got along. And we were in and out less than an hour. You can't even do that.
Yeah, no, I'm not trying to disparage. I think Heritage Health serves a need in the community. I just wanted to share that within this community, we have the FQHCs, we have the health districts that are serving this population of needs. So.
I was just saying that I was in a Heritage, is actually the clinic in Post Falls off of South T Way yesterday as an advocate for a young woman. And it was the patient's first visit. We waited, I don't even think we waited 5 minutes in the waiting room. Literally, I never sat down because there was a veteran there that I spoke to, and they grabbed me and said, "We got to go to the room," is how fast we moved. And we were in there just a few moments. We met very successfully with a nurse practitioner, given referrals on to what the patient needed, and we were right out the door. They were extremely efficient, and I would highly recommend their care base.
Thank you. Any other comments?
Mr. Chairman?
Mhm.
Eric, what is the availability of the Heritage healthcare as far as throughout our district?
I can't speak directly to that other than knowing that they do have the primary but they do have they people sound like limited capacity. Like exactly I guess really the point that I want to make is while as we continue to talk about federal funding sources and whatnot and how those might impact the health district, I think that we should not assume that other similar entities are not going to be impacted. And if the thought is that we're going to hand off all of our services to Heritage Health, I don't know if I think it's premature to say that that's a solution, particularly when we're seeing growth in our primary care services. So again, I don't have all of the information to make all of the decisions, but I just want to make sure that the board is aware of what the information is, that we're working with here at the administration. So as we have these conversations moving forward, we're making the best decision we can.
Mr. Chairman, as we progress through this process, it might be advantageous at some point to invite a representative from Heritage Health or the other folks to collaborate with us in this effort to identify, okay, this is their demographics that they manage, so who does that leave out? Would they be falling into health?
Glenn, I like that suggestion so much would you be averse to us inviting them to our workshop?
No,
I mean, these are central players. I mean, Eric, what do you think?
Well, I would simply caution the board that the message that I keep saying is they don't know any more than we do what's going to be cut. I mean,
Yeah, but at least we can get an idea of what their coverage is. Where are they? What is their mission? Of course, we can't read the future, but at least we can get an assessment of the current.
correct, but I'm not as worried about the current as where we're going to be. I mean, if this was status quo and we were anticipating no changes in funding, everything was moving along as it's been, then certainly plenty of value of talking to others about their current status. But when we're talking about potential significant, very significant changes, we don't know what we don't know is what it comes down to. And I think that the conversations, as I alluded to, I'm reaching out to those folks. I'm trying to keep a pulse on what their changes are looking like. But until we start seeing them gel up, it's exceedingly premature, in my opinion.
There is another spin on it, but your position is acknowledged.
Any other questions? Okay, thank you.
Folks who are not here, any of you, Peggy, or Jessica, or Tim, any of you want to weigh in? Do you have comments, questions?
This is Peggy. The only thing I would weigh in with is I would just, from my past experience working as a clinician at Panhandle Health, because I heard discussion earlier talking about food as medicine, I will tell you that through our clinical services, most of the encounters for family planning, women's health check, Care Plus, not only are they receiving, primary care services, clients are receiving a huge amount of information, smoking cessation, healthy diet, importance of exercise every day. So I think almost every clinician that I am aware of that worked at Panhandle Health really stressed healthy lifestyle. So, I just think, you need to keep that in mind that, as we're moving forward and talking about the importance of nutrition and healthy lifestyle, we've been doing that at Panhandle Health for a long, long time. So there are mechanisms in place, and many of those clinical services feed our other programs, such as WIC and such as health promotion programs. So that's all.
Thank you.
Can I get, Mr. Chairman, if I could just add to what Peggy is saying, it's one of the areas, and you and I have talked about this, that because I feel like I may have come off a little bit overly negative about, unknown federal funding sources, but one of the things we've talked about is if there's a push toward the federal administration addressing chronic illness over treatment, well, the health district, we do preventative work. That's what we do is prevention. So I do think that in many ways, the infrastructure that we have here is uniquely qualified if additional or new funding becomes available to move some of those initiatives forward. So on a positive note, on a potential positive, I am looking forward to seeing what comes out of Health and Human Services. So.
Duly noted. Any other comments? Tim, you've been awfully quiet.
I'm just taking it in. It's all good.
Now you're personally invited on that Saturday. I want to see you there.
Yeah, I'll be there. I don't think my other two commissioners are going to be there.
That's all right. That's fine. You're adults.
Yep.
Any other comments? All right. Are you finished?
Yes, this other item that I added earlier on, my questions were answered in our earlier discussion.
Oh, okay. We're down to the last item, which is to adjourn. I'll entertain a motion.
Chairman, I'd make a motion that we adjourn at this time.
Thank you. Do I hear a second?
I'll second.
Okay, we have a motion and a second. Do I hear any nays, any objections to adjourning? Hearing none, the meeting is adjourned. Thank you, everyone. All right. Well, there we go. Well, Glenn, thank you. Thank you very much. Your input there was solid. Let me ask you a question. And because you have the most experience with this trustee thing, so I'm going to, in a way, ask a favor of you.